Hello everyone, my name is Ogechi Onoha and I am an MSHA candidate at Grand Crayon University. Over the past 15 weeks, I had the privilege of doing my practicum at ASTEM Behavioral Health under the mentorship of Dr. Vivian Umogu. This experience gave me the opportunity to move beyond the classroom and apply the strategic, financial, and operational frameworks. I have studied in a real dynamic behavioral health organization. The project you are about to see is the result of hours of hands-on work, observation, analysis, and cooperation with a dedicated team of healthcare professionals. I am excited to walk you through what I found, built, and learned. Description of site and organization. ASTEM Behavioral Health is a community-based outpatient behavioral health organization with a mission to deliver culturally competent, evidence-based care to individuals and families across diverse populations. During week 1 of my practicum, I sat down with Dr. Umogu to review the organization's mission, vision, and full organizational structure. What became immediately clear was that ASTEM operates across 3 primary service lines: outpatient therapy, telehealth, and intensive case management, each serving a different population need. The organization employs approximately 25 clinical and administrative staff and serves a payer mix of Medicaid, Medicare, and private insurance. Understanding this structure early was essential because it shaped every analysis I conducted throughout the remaining 15 weeks. You cannot improve what you do not fully understand, and week 1 gave me the foundation I needed. Needs assessment results. The needs assessment result was not a single event. It unfolded progressively across the first 5 weeks of my practicum. By the time I finished reviewing the operating budgets in week 2, observing the billing cycle in week 3, analyzing patient outcome data in week 5, and interviewing HR in week 6, 4 major organizational needs had clearly emerged. First, claims were being denied at a rate of approximately 10%, close to the industry benchmark of 5 to 7%, and documentation gaps were the primary cause. Second, patients were waiting an average of 8 days from initial contact to their first appointment. Third, there was no standardized KPI tracking system in place. No show rates, readmissions, and engagement metrics were tracked inconsistently across departments. Fourth, clinical staff turnover stood at 31% annually, a financial drain and a threat to continuity of care. These 4 findings directly shaped the focus of my project. Project topic. With those 4 needs clearly identified, the project focus came into sharp view. The former topic I selected was improving revenue integrity and operational transparency at ASTEM Behavioral Health through lean process improvement and data-driven KPI monitoring. I chose this topic for 2 reasons. First, it addressed the areas of highest organizational urgency, the revenue cycle, and the absence of real-life performance data, both of which were limiting ASTEM's ability to function effectively and sustainably. Second, it aligned directly with my MSHA competencies in operations, financial management, and evidence-based decision-making, meaning the practicum would stretch my skills in areas that matter professionally. The project had 3 interconnected scopes: reducing claims denials through documentation improvement, redesigning the patient intake workflow, and building a leadership-facing KPI dashboard. Each scope reinforced the others because you cannot improve revenue without a better data, and you cannot improve data without better processes. Project goals. Every effective project needs measurable goals, and I was intentional about making mine specific and achievable within the 16-week time frame. Goal 1 was to reduce the claims denial rate from 10% to below 7% by targeting the root causes identified in the billing workflow review. Goal 2 was to cut the average wait time for a first appointment from 8 days down to 5 days through a lean-based redesign of the intake process. Goal 3 was to build a functional KPI dashboard that gave leadership real-time visibility into 5 critical operational metrics: no-show rates, readmissions, rates, billing cycle time, staff turnover, and patient engagement. Goal 4 was a longer horizon goal to reduce staff turnover from 31% to 20% through a workforce improvement strategy presented to HR. Each goal was tied to a specific week's work, which kept the project grounded and prevented it from becoming too abstract. Barriers, real and potential. No project unfolds without friction, and I want to be transparent about the barriers I encountered, both real and potential. The most immediate real barrier was staff resistant to changes in documentation. Clinical staff were already managing heavy caseloads, and the idea of additional documentation requirements was not well received at first. Dr. Umogo and I addressed this directly through brief educational sections that framed the changes as protecting their patients and their reimbursements, rather than adding paperwork for its own sake. A secondary barrier was limiting access to EHR data. Because I was a Practicum student rather than an employee, I could only work with aggregated reports, which constrained the depths of my dashboard analysis. The complexity of the payer mix and the fact that Medicaid rules differ significantly from Medicare and private insurance coding requirements also add an analytical challenge. On the potential barrier side, the most significant risk is sustainability without a named internal champion. A well-built dashboard can simply go unused once the Practicum student walks out the door. I worked to address that from the beginning. Implementation. Implementation was structured across 4 deliberate phases that tracked closely with the 16-week plan Dr. Umogo and I developed together at the start of this practicum. Phase 1, covering weeks 1 through 4, focused on assessing and diagnosing, completing the SWOT analysis, reviewing the project, conducting stakeholder interviews, and participating in a quality assurance meeting to understand the compliance landscape. Phase 2, weeks 5 through 8, shifted into analysis and design, building the initial KPI tracking sheet, mapping the root causes of claim denials, conducting the HR turnover analysis, and reviewing the organizational marketing presence and referral courses. Phase 3, weeks 9 through 12, moved into building and proposing, redesigning the intake workflow, drafting the process improvement proposal using lean methodology, developing technology recommendations, and completing the service line expansion feasibility study. Phase 4, weeks 13 through 16, was about finalizing and presenting, reviewing the ethics framework, completing the patient's experience plan, finalizing the capstone business case, and delivering the executive presentation you are watching right now. Project outcomes. I am proud to report that the project produced measurable results within the 16-week time frame, and I want to walk you through those numbers with appropriate context. The claims denial rate dropped from approximately 10% at the start of the practicum to roughly 8% by week 15, a meaningful improvement, though we set the target below 8%, so the work is not finished. The patient intake wait time came down from 8 days to approximately 5 days following the redesigned workflow, with staff feedback indicating that the new process was cleaner and more intuitive. The KPI dashboard was successfully built and presented to leadership, tracking 5 lives metrics: On the staffing front, while turnover improvement is a longer-term outcome, preliminary feedback from a staff pulse survey suggested improved morale following the workforce strategy presentation to HR. These outcomes are both a source of pride and a reminder that sustainable change in healthcare administration is a marathon, not a sprint. Stakeholder reception. One of the most meaningful parts of this practicum was witnessing how different stakeholder groups responded to the project. The Tumogo and executive leadership were enthusiastic from the start and remained actively engaged throughout. During the Week 15 feedback section, Dr. Tumogo described the KPI dashboard as exactly what the organization had been needing, which was deeply validating after the hours invested in building it. The billing and coding team, while initially cautious, became genuine partners once they saw that the denial root cause mapping validated concerns they had been raising internally for some time. They even volunteered to pilot the new documentation checklist before any formal rollout. Clinical staff presented more of a mixed picture early on. Change fatigue is real in behavioral health settings, but the education sections shifted that dynamic noticeably. The HR director responded to the workforce strategy memo with immediate interest in implementing the onboarding and compensation bench marking recommendations in the upcoming fiscal year. Project sustainability. Sustainability was something I thought about from week one because I knew that a practicum project has a natural end date. The question I kept asking myself was, what will still be running 6 months after I leave? I am glad to report that leadership has committed to embedding both the KPI dashboard and the reversed intake workflow into standard operating procedures. Perhaps the most durable sustainability mechanism is the documentation checklist, which has been integrated directly into the EHR new notes template. So it now appears automatically whenever a clinician creates a note. That is not an add-on, it is built into the workflow. Dashboard ownership has been formally assigned to the Quality Assurance Coordinator as part of their revised job description. Documentation improvement training has been scheduled as a recurring quarterly competency. The intake redesign steps are being written into the patient access policy manual, and the feasibility study identified 2 federal behavioral health grants that could fund longer-term program expansion, creating a financial runway beyond this practicum. Next steps and handoff. The formal handoff of this project will take place during week 16 when I will compile all deliverables into a practicum project portfolio and present it to Dr. Umogo and the full leadership team. I will then provide a digital copy to the quality director, the HR, and the billing manager, each receiving the sections of the project most directly relevant to their area. That intentional segmentation was important because it made the handoff actionable rather than symbolic. Looking forward, the next steps are concrete and time-bound. The billing team is set to complete the EHR documentation checklist rollout in Q3 2025, and we begin tracking monthly changes in the denial rate. HR is targeting Q3 to Q4 for the reverse onboarding program and the compensation benchmarking study. The quality coordinator will present the first full KPI dashboard report to the board of directors in Q4 2025. Grant applications from the feasibility study are targeted for Q 2026, and the intake workflow will be formally reassessed every 6 months using the Lean framework. Professional goals and leadership. When I entered this practicum, I set 4 professional development goals for myself, and I want to be honest about where I started versus where I ended. My first goal was to develop genuine strategic thinking, not just understanding strategic conceptually, but being able to apply a SWOT analysis, build a business case, and conduct a feasibility study in a real organizational context where the decision had real consequences. I achieved that. The second goal was financial acumen, specifically the ability to read and interpret a departmental operating budget and translate findings into actionable recommendations. Reviewing Aston revenue streams and cost drivers in week 2 pushed me well beyond what any classroom case study could have offered. My third goal was data-driven leadership and building the KPI dashboard from actual patient data and then presenting it to an executive team was the most concrete evidence I can offer of that growth. My fourth goal was executive communication, learning to adapt the same findings for clinical, financial, and HR audiences, each of whom speaks a different professional language. What I learned: if I had to distill 15 weeks at Aston Behavioral Health into 5 lessons, these are the ones I will carry into every leadership role I hold going forward. First, healthcare administration requires you to speak multiple languages simultaneously: finance, compliance, clinical care, and technology. And solid thinking is the enemy of effective leadership. Second, data without context is just noise. The KPI dashboard only became meaningful when it was tied to decisions that leadership was already wrestling with. Third, process improvement is fundamentally a people problem. Every workflow bottlehead I found at Aston had a human story behind it: burnout, unclear expectations, or inadequate resources. Lean tools only work when people trust the process and feel heard. Fourth, sustainability has to be designed intentionally by impending into job descriptions, policy manuals, and calendars, because it will never happen by default. And fifth, perhaps most personally, Dr. Umogu modeled servant leadership every single week by prioritizing the team and patient outcomes over personal visibility, and that directly shaped how I approached every interaction during the experience. Closing. I want to close by expressing genuine gratitude first to Dr. Vivian Umogu, whose mentorship went far beyond signing off on weekly hours. She opened doors, challenged my thinking, and modeled the kind of leader I am working to become. To the entire team at Aston Behavioral Health, the billing staff, clinical providers, HR professionals, and leadership, thank you for welcoming me, being honest with me, and trusting me enough to act on some of what I recommended. To Grand Crayon University and the MSHR program, this practicum structure is exactly what professional graduate education should be: applied, rigorous, and consequential. I leave this experience with more than a project report. I leave with a clearer sense of the healthcare administrator I want to be: one who leads with data, serves with integrity, and builds systems that outlast their creator. Thank you.